eminent speakers. Let me thank my course speakers and co-instructors for this instruction course. So refractive surgery has come a long way from giving independence from glasses to now redefining the quality of vision. Let me call Dr. Narayanankutti, the senior most and pioneer in refractive surgery in Kerala, to talk on. Sir will be talking on ideal candidate for refractive surgery.
Good morning, everybody. Shall I start?
Yes.
The topic given to me is ideal candidate. I feel that we should have some judicious flexibility, and there is nothing called ideal now. So, judiciously, you have to employ the flexibility. The basic patient selection criteria, the age below 20, preferably above 21 years. But in certain cases of job requirement, marriage, etc., you can do after the 18. But below 21, the chance of regression is more. That's why ideally it is above 21. Then stable refraction for 1 year, refusal to continue glasses. You're using contact lenses, soft lenses you have to withdraw 2 weeks before, and rigid lenses 4 weeks before. Contact lens intolerance, absence of corneal pathology, realistic experience from the procedure, properly obtained informed consent. Absolute contraindication of corneal abnormalities, external eye diseases, significant cataract, pregnancy, lactation, uncontrolled diabetes, glaucoma, uncontrolled systemic autoimmune syndromes. The possible contraindication, abnormal wound healing in the keloid, history of herpetic keratitis, controlled diabetes, glaucoma, and autoimmune disease. Investigation, accurate refraction using retinoscopy, slit lamp biomicroscopy, pachymetry. Ideally, should be above 500 or 490 microns. For me, it is above 490 microns. Sherman's test, tear production above 10 mm, tear film breakup time about 30 seconds, the normal intraocular tension by pulsar tonometer, binocular indirect ophthalmoscopy rule out retinal conditions, topography and pentacam scan to exclude anterior or posterior ectasia. You have to very carefully study in the pentacam anterior sagittal map, anterior and posterior elevation maps, and cornea thickness map. Don't reject patients simply because they don't, without doing the retinoscopy. In the recent changes in the glass power also, you should not discard the patient. Before you doing retinoscopy and show that actual power is less than the power of the glass they are wearing. Because the accommodative element is not taken into account, and hence the retinoscopy value, if they accept, that should be taken into account. Don't reject a patient with dry eyes until you trial lubricant eye drops with Hylice and cyclosporin eye drops, and till you exclude the history of oral medicines like antihistamine, diuretics, systemic conditions like thyroid disease. You have to see the tear breakup time, tear meniscus, and blinking rate in addition to the Sharber's value. Don't reject a patient with low PACI value also until you assess the visual acuity, quality, and the patient actually which quality and what is the patient need. Patient with higher powers may be already adapted to less resolution, less contrast sensitivity, and poor binocular vision. Also, the pupil diameter, residual bed after ablation are to be considered. The age of the patient and his profession. You can modify the optical zone, can undercorrect. Marginal adjustment you can do even in the residual field. Can accept certain keratoconus cases. This I want to stress. Certain selected cases we can even do it, although it's a contraindication. The patient has low power, patient should be willing for C3R procedure later or as a combined one. Patient has come for the refractive surgery to fulfill his job requirement or for some other genuine requirements like marriage. In certain cases, the combined procedure has even reversed the keratoconus. Criteria selection above 490, Sherman's test I already mentioned, pentacam and this refractive status, the sphere should be below 10D and cylinder below 5D. In one case where a keratoconus case, they got a low power only, 1.75 with a 1.75 cylinder. And the pentacam shows that posterior ectasia in this case, or the early case of keratoconus. And the surgery was done in 2018 in this case. It's a combined procedure, PRK with the C3R. And the post-operative, the vision was 6/6 partial, both eyes. And after 1 year, the pentacam shows it's completely reversed, like you can see that. And even now the patient continues the same vision, and the pentacam readings are normal. Thank you so much.
Thank you, sir. It was very really informative. So one thing, do you? No, sir. Please come. This is, sir. In glaucoma, you said if once you control, will you take the patient for refractive surgery or established case of glaucoma?
Glaucoma still, if it is controlled, I'll take for PRK, not for LASIK.
Okay. Sir. Next, I call upon Dr. Anil. He is the head of cornea services at Amrita Eye Institute, Ernakulam, Kochi. He'll be talking on surface ablation techniques.
Yeah. Thank you, Kala, for the opportunity. So PRK seems quite an outdated procedure now, but with the eminence of this lenticule-based procedures like Silk and Smile, but still it has its relevance. You know, if you look at some of the major institutes, like for LV Prasad, almost 65 to 70% of the refractive surgery, what they do is PRK. Mostly other part, it's mainly femto or femto or Smile. So we all owe the XMR-based refractive surgery. We all owe to this person who had this thought process and had it done as early as 1985. The major advantage with surface ablation is that absolutely there is no flap. So all these disastrous complications we don't get to see. So which are the patients we do surface ablation for? One is this low or borderline pachymetry. Sometimes you see patients in whom, like you see a borderline pachymetry, then you give them for an ICL workup, and we found that the anterior chamber depth or some other parameters not really matching. In such a patient, you can revisit and you can think of doing a PRK in such a patient. If it's a very flat K or a very steep K, LASIK, this regular microkeratome LASIK is not a great option. With femtosecond LASIK, it is possible. If you have a history of epithelial basement membrane dystrophy or recurrent erosion syndrome, then LASIK is a big no-no. And in PRK, actually, PRK or PTK is actually the treatment for recurrent erosion syndrome. So if you have a tendency, sometimes you see that some patients, when you take a flap, you see that the epithelium is, half of it has come off. In such patients, they are prone for recurrent erosion. Their adhesion complexes are not great. And such patients, I think it is PRK, this is the preferred procedure in such a patient. And if you have a very narrow orbit in which you cannot keep the suction ring, or if you are involved in contact sports, it may not be a great idea. Then if you have an irregular cornea, especially post-keratoplasty, post-RK, or post-LASIK residual refractive errors, PRK appears a much better option, especially the topo-guided PRK. So we know that the biomechanical strength of the cornea goes down in every procedure, and if you make a flap of about 90 to 100 microns, there is a loss of corneal strength of about 14%. And if you make a 140 or a 160 micron flap, there is a loss of corneal strength of 30%. So with PRK, the loss of strength is much lesser. So I'm also not a great fan of PRK unless the patient is otherwise unfit for LASIK. I don't prefer PRK. But this was I think, collection of cases, 36 cases in whom this I was in the previous institute. in which regular LASIK could not be done. And I think as you see in the results, most of them were high myopes. The mean pre-op spherical equivalent was minus 9.35, and it came down to post-op was only 0.23, which means he or she can be essentially off glasses in most of the cases. The major problem with the PRK is the pain and the slow recovery, the reason why people shun away from surface ablation. And in the long term, the PRK haze is the thing that is important. So I'm not going to the details, but I think I would say there is a normal response that we see. So when there is some cut in the epithelium, whether it's a PRK or a LASIK, there is some keratocyte activation, there is some inflammation happening, and there is a normal response, and we are expected to, the response will come down within 6 to 24 days. But if it goes to the next level, then only this haze will happen. So the keratocyte activation and inflammatory mediators will bring in myofibroblast and fibroblasts, and with that will cause the haze. That is the problem with PRK. So that is why initial period in the 90s, I think PRK was quite popular. I mean, early 90s it was popular. By early 2000s, I think the popularity came down because the mitomycin was not available. The resurgence of PRK happened after use of mitomycin, and we all know that 0.02% is the one that we usually use. I think we have to be careful in that Asians have definitely a higher incidence of stromal haze. Just like we get more keloid, we can get more haze also after excimer laser, and that has to be taken into consideration. So as a routine, we keep about the mitomycin application is for about 10 seconds for every diopter or 1 second for every micron. So I think I'll just touch upon the preferred practice patterns of PRK surgery, which came in AJO 2020. So in the preoperative, we have to, especially in Asians, we have to give some importance to the blepharitis, because if there are inflammatory mediators already in the conjunctival cul-de-sac, the chance of haze would be more. So if you have MGD or dry eye, treat it very well and then only take up the patient. So if you have MGD especially, I think it's a wiser idea to give steroids preoperatively. I think for 4 weeks you can really bring down the inflammatory mediators in the cornea. Then if you have if you have eye rubbing, acne and all that, also everything has to be taken care of. In the interest of time, I won't be going into the other details. See, some of the systems, I think, produce more haze. For example, LiDAR Vision and Summit technology had more late haze. We don't know exactly what is the reason for that. 1 minute more, no? So, in LASIK, there is, I think I won't go into this. Basically, intraoperatively, mitomycin is the one that you have to use. So we can actually use contact lenses, and the contact lenses can be impregnated with ketorolac, and that will reduce the post-op pain. I don't as a routine use it. Quite often I use this patches which are available nowadays for the intense pain that you have for the first 24 hours. We have buprenorphine patches which are approximately 1,000 rupees. That is quite useful. I think the plastic surgery people and all quite often use it. Only thing is, in a small percentage it causes nausea, but otherwise they are well accepted. Post-operative pain is the thing that you have to be careful about. You have to give tramadol and paracetamol. Ensure that the follow-up is very good. And topical steroids have to be given for 8 to 12 weeks. And you have to make sure that you avoid sun exposure for about 6 months. So once you get a late haze is the thing that we are all worried about. I think the treatment is much more difficult. You have to give a topical steroids for about 2 months. You can try doxycycline, vitamin C, UV protection, and lubricants obviously for 6 months. Tacrolimus is something that I use for haze, when especially people with blepharitis, I use tacrolimus in the long term. So I would like to conclude saying that PRK is a procedure still going to stay here. I think 2 big procedures have stood the test of time. One is the PRK and the surface ablation, and second is the lenticule-based extraction. And it's important, slightly more important, to pay more attention to the surface and the inflammatory conditions in the cornea and the post-operative care if you're doing PRK. Thank you so much.
Thank you, Neil, for that nice paper. As Anil pointed out, the main problem is the pain and the haze. If that is pain and haze is not there, so many more people would have adopted for this particular procedure. Now, next speaker is Dr. Kala Baby Thotam, and she will be talking to you on her LASIK experience.
Good morning. Good morning, everyone. As Dr. Narayanagurti told, the popularity of PRK has come down when LASIK came, mainly because of the less postoperative pain and faster visual recovery. In LASIK, as you all know, what we do is we create a corneal flap, lamellar flap, and lift the flap and ablate. The excimer laser is ablated to the stromal bed, and the flap is repositioned. We can do LASIK either with microkeratome, mechanical microkeratome, or femtosecond laser. I'll be dealing with LASIK with a mechanical microkeratome flap creation. History, Jose Baraka is known as the father of refractive surgery. He invented the microkeratome, and Ioannis Pavlikaris in 1990s invented the hinge creation. And later, the microkeratome, what it comprises of a high precision oscillation blade system which docks into the suction ring and to create a lamellar corneal flap when the eye is held under high pressure. So various companies have come up with a mechanical microkeratome, the Moria, Bausch & Lomb, AMO. I think most of the companies have stopped manufacturing except for Moria because of the popularity of femtosecond laser. The microkeratome unit consists of a suction ring, cutting head, drive unit, and a central unit. There are various types of microkeratomes available: translational, rotational, linear, rotary. It's a video of LASIK procedure. After applying the topical anesthesia, we put the speculum and the ring is placed. Mostly I have used Zyoptics XP microkeratome. It gives a superior hinge. After applying the suction, use the head. It has got, it creates 160 and 180 microns flap thickness. Based on the corneal diameter and corneal thickness, we decide on the size of the flap as well as the thickness of the flap. We have we can create an 8.5 and a 9.5 millimeter flap. After the laser, excimer laser ablation, we replace the flap and align with the wash. Microkeratome, even though it is not so popular, but it is one of the main type of LASIK procedure, and it has we have done lots of surgeries without much problem. It is a proven history, and it compared to femtosecond laser, it's of the cost is very less, and the surgical movement is very fast because suction, we don't have to shift the patient to another bed or change to another room for flap lifting and repositioning. The same bed, we can finish the case, both eyes, in 15-20 minutes. And it can create a flap even with anterior stromal opacity, which is not possible with femtosecond laser. But even though it is simple and it has, we have done many cases without any complications, but there are a few complications, but it is even though it is rare, the most common complication is epithelial defect. It's because of the shear force of the microkeratome head and the flap irregularities. Mainly what we see get is buttonhole mostly in the steep corneas or free cap, in flatter corneas, and any type of incomplete flap. It can be due to loss of suction or inadequate suction. And it postoperatively, the first day the flap misalignment, maybe because of rubbing. It's a late complication of LASIK, an epithelial ingrowth. And one of the major complications of any refractive surgery procedure is undercorrection or overcorrection, and it can have regression and post-LASIK ectasia. So we should LASIK enhancements. We can consider LASIK enhancement. After a minimum, we have to wait for 6 months and wait for a refractive stability before we should attempt for LASIK enhancement. Thank you.
Thank you, Dr. Kala. This is a limited time. You have done it justice with a lot of clarity. Thank you. And this is the most performed surgery in the refractive surgery, LASIK.
Next, let me invite Dr. Jairam. He is the medical director of Precise Group of Hospitals. He will be talking on femto LASIK.
Good morning, all. I thank Dr. Kala for inviting me. Today I'll be talking regarding our experience with femto LASIK. So as already described, LASIK is the most commonly performed refractive surgery worldwide, but recently femto lasers, after its introduction in 2001, it's around 10 million cases have been done till now. That's what the data shows. So femtosecond laser is an infrared laser with wavelength of 1053. Actually, the pulse duration is the difference. Actually, YAG laser is also an infrared laser, but the pulse duration is in nanoseconds. But when it comes to femtosecond range, the amount of collateral damage due to the cavitation bubble decreases. So the general principle is photodisruption. The laser energy results in plasma formation, and the expansion of the plasma creates cavitation bubbles, which separates the tissue plane. Excimer laser, as you all know, is photoablation, which sculpts the cornea. So different femtolaser platforms use different pulse energy, duration, frequency, applanation surface, laser delivery pattern, type of flap creation. So we are using femto LDV of Zymer, its latest model Z8. So to compare between femto LASIK versus microcatome LASIK, it gives better control of flap diameter, flap thickness and hinge width, hinge position flexibility, lower incidence of epithelial ingrowth, few flap related complications, that is one important factor, and improved visual outcomes due to lesser induction of higher order aberrations. So a lot of studies are there with which shows better thickness predictability, fewer higher order aberrations, a better contrast sensitivity, and increased T-butt. So in LASIK, it's the flap is a meniscus flap, and in femto LASIK you can create a uniplanar flap with better thickness predictability with not much of variation. That's around maybe less than 5 microns. So our laser machines are femto Z8 and MEL80. So this is the window showing the different flap parameters you can manage. You can adjust the flap thickness, flap diameter, then the cut of the edge, then the energy of the bed and side cuts and all counts you can regulate. This is a case. So you can, it's a 9 millimeter flap with This is the bed creation. Then it's a side cut. The duration is around 25 to 28 seconds. Then as you can see here, you can lift the flap. It's pretty easy due to its low energy, high frequency. The bed is very smooth. Then you can do the examer and then complete the procedure. So complications are less with femtoLASIK. What I have experienced more of a few cases of suction loss in the initial cases. Vertical gas breakthrough and opaque bubble layer can happen, which will create problems. So I have done 244 eyes with a mean age of 28.4 years. 96% of eyes achieved 20/20 vision. None of the patient required retreatment on another date. Complications, as I mentioned, was suction loss. In the 3 patients, we could reapply with increased diameter and greater depth. The one had a difficult flap dissection that I will show you. It's the next case. 32-year-old female patient with minus 3.5 2-cylinder and left eye minus 2 with 2-cylinder. So actually, due to a mistake by the technician, the initial cut was made with a very low energy, so we couldn't elevate the flap. The second cut was made with a larger flap with a deeper 130 micron thickness, and initial flap was attempted with 100 micron. As you can see, the flap, it's very difficult to elevate. You can see the struggle. The right side, you can see a tag also. So after a little struggle, I could remove. Then I could see a tag. I reflected it and did the examer. Then I could make out that the 100 micron, 130 micron, the tissue in between was partially dislodged, and I removed it from the undersurface of the flap, which was partially adherent to it. Then it was reposted. Next day, patient vision was 624. After 1 week, it came back to 6.6, and the topography was normal. So to conclude, use of femtosecond laser has only added to the beauty of LASIK with better visual outcomes, greater quality of vision, higher accuracy, and lesser side effects. The excellent outcomes of femtoLASIK presents a formidable challenge to even newer procedures of flapless refractive surgery, which is recently gaining popularity. Thank you.
Thank you, Dr. Jairam. From flap-based refractive surgery, we'll move on to lenticule-based refractive procedure. Refractive lenticule extraction is becoming the procedure of choice due to its high precision and biomechanical stability. Let me call upon Dr. Rohit Georgie Matthew. He's the head of cornea and refractive services at Lotus Eye Hospital, Kochi.
Good morning all. Thank you Dr. Kala for the opportunity given. So as mentioned, like already the well-known surgeries are LASIK and PRKs. I'm not against any older techniques because it's all an innovation which is happening. So the latest generation is called the CLEX, the keratolendicular extraction surgery. I'll be talking about the SMILE. So no financial interest on any machines. So it's a minimally invasive laser correction with keratolendicular extraction, which has been done with femto. And the advantage over the older procedures, there is no flap. It's a single procedure. Only one machine need to be used, and only completely it will be femto lasers used. And intrastromal keratomyelitis is being reinvented as refractive lenticular extraction. So these are the 4 new generation femto lasers for the lenticular extraction surgeries. This is first one is Visumax 500, which has been launched 10 years back, and 800 is the current one. And the Femto LBD by Z8 by Zimmer is there, and Elita by J&J, where Dr. Kala will be talking, and Atos by Schwind. So the basically all the treatments are being done on the pupillary and visual axis, and the pulse duration frequency is from 500 kilohertz to 20 megahertz. It depends upon the machine, and the energy per pulse is 10 nanojoules to 150 nanojoules. The laser spot size is 0.5 to 1 micron, and 3D displacements is 2 to 5 microns. It's all a spiral laser delivery which has been delivered. So the mechanism is the ultra short laser power pulse at very high speed. It bonds between cell broken by photo disruption, and micro gas bubbles create tissue cleavages, which helps in precise tissue transaction at the focus plane within the cornea. So the dimensions are, what I take is usually optic zone of 6 to 6.5, cap diameter is 0.5 to 1 over than the optic zone, and the cap thickness is 110 to 120 microns. Side cuts is 2 to 5 millimeter, placed at 90 to 180 incision, and the refractive correction determines the shape and the size of the lenticle. So this is a cross section where you can see the first one is a lenticular cut which will be done, second is a vertical cut, third is the cap, and the last will be the side cut to remove the lenticle. So procedure is basically the data entry onto the machine, and topical anesthesia, eye washes and eyelid cleaning, and curved conical contact lens is being used as a medium, and the eye is brought to the contact lens, and the patient aligned at specific light. The patient will be asked to look onto a green color light, and the suction is activated and the laser is delivered. So the time duration of the laser depends upon the machine, like the size 800 is having around 5 seconds it will be delivered. The procedure continues like the side cut is open, the lenticular separated from the anterior stroma, and then the posterior stroma, and the lenticle is removed. Post-operative, I give a antibiotic and steroid combination for a week, and artificial tears and protective glasses. The intensity and the duration of the medicines can be reduced by these type of lenticular based surgeries, whereas in LASIK I usually give a little more longer. So the CLEX benefit is basically it's a convex shaped lenticle, subbasal nerve plexus relatively spared, and the subepithelial plexus are also spared. The stromal intermission dents at the periphery are not affected. The corneal sensation is much better than LASIK, and the electronic dry eye is very less. So this is a video where the patient is brought to the machine. There will be a cone which will be the interface, and once the suction is activated, the laser is started. So you can see the flap cut, vertical cuts, and last the side cut. Once the patient is brought to the microscope, the side cut is open, separating the posterior and the anterior lenticule. And after separating it, the lenticle has been either rolled out or pulled out. So this is a study which was conducted in, published in 2014 JCRS, where the 3 months results showing the smile is having a much better refractive accuracy, dry eye and less dry eye and better contrast, and induced aberrations are lesser. And the contraindications are mainly already spoken by Dr. Nanakuti sir. Corneal ectasia condition, corneal scars, presbyopia, and pachymetry less than 480 microns, and residual not less than 260, and small papillary fissures, and anxious and uncooperative patients are unable to do it. So the main complications which happen from smile is suction loss. Redocking after suction loss is a task, and flap tear can happen while during the lenticular extraction, and lenticular irregular dissection is another complication which happens when you have a thinner lenticule, and it's a learning curve because most of the cataract surgeons will be able to do a lenticular extraction surgery. So I conclude, there's no flap, the anterior stroma is not weakened, very high powers up to 10 diopters of sphere and minus 5 cylinder power can be corrected. Even hyperopic correction also can be done, and less higher order aberration, minimally invasive, and it's a gentle procedure, and all in a single step, and the biomechanics are less affected, and iatronic dry eye is less, and the wow factor, it's like the day one you'll get 6/6 vision. Thank you.
We thank you for that nice presentation. Now we call upon Dr. Kala to present her paper on the latest technology in the refractive surgery, namely silk.
Thank you, sir. Dr. Rohit has already mentioned talk in detail about the lenticule extraction. I'm just adding one more topic, just about the silk smooth incision lenticule keratomiliosis by Johnson & Johnson, and I don't have any financial interest, but we have started doing it. I thought I'll talk about it. Silk, it uses the next generation femtosecond lasers to create a tissue bridge-free incision, thereby giving a novel ablation of lenticule, biconvex lenticule. That is the uniqueness of silk procedure. Compared to other lenticule extraction, the lenticule shape is biconvex. It's mainly achieved because of the short pulse duration and the small spot size without any spacing. The energy used is 40 nanojoules, and it's a continuous spot. It creates a tissue-free dissection, which is easy to separate the lenticule, and it gives a biconvex shape, which is symmetric to the corneal curvature. And because of this biconvex shape, the manipulation, the wrinkles formed while manipulating the lenticule separation is very minimal, and thereby the postoperatively the vision and the day one vision and the corneal clarity is much better. And as any other lenticule extraction, the cornea biomechanics is better preserved, and less damage to the corneal nerves, thereby causing less dryness and better spherical aberration control also. The procedure is we do the docking. The PI is attached to the docking femto machine, and it is bring down to the suction ring after entering the patient data. We use 6 millimeter as optic zone. Usually go for the cap thickness of 100 or 110. We have done up to -8 diopters of sphere with astigmatism, compound myopic astigmatism. The initial, after identifying the incision, the anterior plane pocket is made to create an anterior. The plane is separated. Next, the posterior plane is we made a pocket, and complete the anterior plane separation through that pocket, including the transitional zone, is separated. Identifying the plane is little difficult in the initial cases. In 1 or 2 cases, I think we can identify the plane. Especially in high powers, it is little more easier because the lenticule will be more thicker. After the separation, it is removed in toto. It's a day 1 post silk. It's the cornea is clear. Only the incision, we can make out the incision mark here. It's a post-op post-silk 1 week post-op pentacam picture. So the advantages of the lenticule extraction, Dr. Rohit has already explained in detail. So thank you.
Thank you, Dr. Kala. This being one of the latest method, only very few centers in India were behind this. And most of the people, including myself, have not seen this procedure being performed. So we expect more questions on this technique from the audience.
So we are coming to the end of the session. Last talk will be by Dr. Sujit Naina. He's the senior most cornea specialist at Trinity Eye Hospital. Over to you, Dr. Sujit. He'll be talking on laser-based refractive options in presbyopic age group.
Very good morning. Thank you for this opportunity. The topic of this last topic of this IC is laser-based refractive options in pediatric age group. The title is laser-based refractive options, and it's not about the presbyopic LASIK. So, excuse me. Can you make it present to you? So, as this quote says, many of us, the life starts at 40. After the initial hurdles in life, they start exploring the world after 40. So but that's about the mindset. The body has something else in store, and it starts showing up the signs of aging. Especially it starts with the eyes, and they start thinking that my vision is not as good as it used to be in the younger age. It's basically due to the difficulty they face while adjusting with the multiple focal points as they approach the presbyopic age group. We are sometimes surprised, like why at 40 they come with this request to undergo a refractive surgery. Actually, by the time when you look at it, I think there is one article also on it. They've studied why people come back at 40 for refractive surgery. They are more settled in life. They are financially stable. Sometimes they are actually, in my personal experience, they are mostly inspired by the younger generation, the children who have undergone LASIK, and seeing the wow effect, they want to try it in themselves. Now they think that they have the wisdom to judge and decide by themselves. They don't have to depend upon the parents. So all these things, and health as an investment, not as an expense, they are considering. So, and now they are coming back at 40 requesting for a refractive surgery. But what is in the mind is something different from what we see. It is just a journey that begins at 38 or 40, and they have to go through another 10 to 20 years, which is a dynamic process which is affected by multiple factors. So it's not as easy as in the younger age group. They correct it once and they have the result for a longer period. So this is a main challenge as a consultant or as a doctor practitioner. We have to tell them, or as a challenge for the practitioner is to give the same visual quality or optical quality for far distance and intermediate. So this is adapted from an IGO journal, article in the IGO journal, which in which the age-wise categorization of the refractive surgery was shown. So above 40, they have categorized it into two groups: the one with the DLI OK and other with the DLI less. So DLI is the newer concept of grading the dysfunctional lens index as a new term, which tries to explain the dysfunction of the clear lens. Morphologically, there is no cataract, but the lens is not acting or giving the clear image as it used to be. So this is the index which they see or look at to decide on an early refractive lens exchange. So anything more than 7, they say they are having good visual index, visual acuity, and anything less than 5 is said to be a very bad DLI. So with that concept, anything more with a less DLI, they are suggesting refractive lens exchange. Better DLI, go for the laser. The laser options. Can you make the other presentation? Okay, I'll do it. Okay. Thank you. So laser-based options that can be offered are basically what is practically possible is LASIK. We used to do conductive keratoplasty and all previously, but I think it has been phased out due to the poor results or poor long-term results. In LASIK, we have 2 options, either a monovision LASIK or a Presby LASIK. And in a difference to what a normal younger patient LASIK, we need to have a very long chat with the patient. We have to patiently understand what is the patient's requirement. And they have to understand right from the optics of presbyopia to what is going to happen in future for the next 10 to 20 years regarding the normal change that is expected in the vision. So this is what I stressed in the title. When you look at the presbyopic age group, it need not be always a presbyopic LASIK. You can always offer them a normal LASIK also, but they should understand that they have to use glasses for the near vision. That is the simplest thing that you can do. The second thing is, if they are very persistent that they want to be independent or less dependent on glasses, that's when you consider the presbyopic LASIK option. And it again depends upon the basic refractive error they are having, whether they are hyperopic, emmetropic, or a myopic patient. So the presbyopic LASIK, again, presby LASIK, as it is called, has 3 types are there. One is the central, peripheral, as well as the laser blended vision. Going into too much into the details of this is beyond the scope of this talk, because this just to introduce what are the options in the presbyopic age group. These are the machines that offer the treatment of presbyopic LASIK. 3 main types. The first type is the central presbyopic LASIK, that is more popular and more done in most of the places where they are conducting it. The basic principle here is the central cornea is a multifocal ablation, and where the central cornea is used for the near, as well as when the peripheral cornea is used for the distance. The ablation is less, and it takes very less tissue from the center of the cornea. In peripheral LASIK, it's I have time now, sir. Last talk, no? So peripheral, it's just opposite. The center is for the distance and the periphery is for the near, which is not a physiological thing, and it's not a very popular method. The results from the literature shows that there is definitely a loss of the distance vision by 1 or 2 lines in more than 40 to 50% of people. They have good near vision, but the loss in the distance vision has to be accepted and told. Another thing is the increase in number of the retreatment. The retreatment is almost 20 to 25%. Basically, probably these are the reasons which they have told that it's inability of the older patients to accommodate. The nomogram is not refined, the healing responses, nuclear sclerosis, and all those things. The other option is the laser blended refraction, laser blended vision. So, 2-3 slides. Here they are. It's also a popular method. Here, what they are trying to do is it's just like an EDOF lenses. They are trying to adjust the spherical aberration and trying to increase the depth of focus. And in this, what is happening is actually we have a distance between the distance and near. We have a blur zone. They are trying to blend that near vision to that blur zone by inducing a little bit of spherical aberration, you have to do a plus 1.5 diopter test in the non-dominant eye and see whether the patient is accepting it. And that is one test which you have to do and see whether this patient is an ideal candidate. Another option is going for a standard micro monovision. Here it's direct one eye distance, one eye near, almost 1.5 diopters you undercorrect. It's very clear, one eye distance, one eye for the near, but in the other one there's a blend zone which is adjusted in the non-dominant eye. Here the adaptation time is little more, but there is always a second chance here. If the patient is not adapting, even after 1 month, you can even, you have to tell the patient initially, you can even go for that either. And non-dominant eye also, you go for full correction and just they have to accept it, the near vision with glasses. So it's basically a trade-off, like you have to compensate at some part of your vision, either distance or near, and it's we have to understand that we are training our brain to learn the new type of vision. Patient selection, you have to check the dominant eye, avoid high demanding patients. The professional requirement has to be well understood. The trial of 1.5 diopters is important, and better avoid low myope presbyopes as well as the emmetric presbyopes. And the general principle about the planning is, in the presbyope hyperopes, it's always presbyLASIK or refractive lens exchange that is advised. Low to moderate myope presbyopes are a difficult group where you have the option of blended monovision or the LASIK with the near vision. High myopes always go for either phakic IOLs or selective lens, refractive lens exchange, understanding all the proper risk factors. Myopes, again, as I told, it's just the same thing. Low myope presbyope, why it is difficult is because if you undergo a LASIK with the distance correction and just near glasses, they are never happy with the near vision that they used to enjoy without glasses. If it is a monovision, they have a compromised depth perception. If it's a multifocal ablation, the lack of clarity is always a complaint. So this is a very small personal experience which I thought I'll discuss, but there's no time, I'll skip this. So in conclusion, we need more chair time with the patient, multiple sittings, proper patient selection, age slab and patient requirement should be well understood, realistic promises should be given, reversibility and repeatability is always should be kept in mind, and alternate options should be discussed, and this is still evolving. Thank you.
Thank you, Dr. Sujit. Any questions from the audience?
Anyone from the speakers who have done presbyopic LASIK experiences to share, I'd like to know.
I usually advise undercorrection or monovision. LASIK only I have done, not presbyLASIK.
Yeah.
Non-dominant I do it.
Yes, sir.
All those people who want.
I had the
The only thing binocular vision is suffer, but that age I think it is okay.
I was fortunate to do few cases of supracore when we were in Vasan. That was 2013 to 2015. But unfortunately, I don't have a proper maintained Excel of all those details. We did almost 50 eyes. The immediate result was very good. But definitely there was at least one line reduction in the distance vision. The problem was we did only the hyperopic patients. Hyperopic patients above 45 years with at least one diopter hyperopia. And 1 or 2 cases we did emmetropia, in which we did only one eye. So the hyperopic patients, we were doing both eyes. Myopic, the nomogram was not described at that time. After that, I had to change the hospital, so I don't have the follow-ups of most of the patients, but 3 or 4 patients persistently follow me. And they all have had regression, and they are happily using glasses now.
They are not happy. Unaided vision is not good. That's why they are following another hospital.
I also have used only one patient, Presbyond. So when the trial of this software is available, but that patient was happy, but one patient is too less to make any comment about. Yeah, that we don't know exactly. Yeah. No, but I think it's very important to do a contact lens trial and convince the patient, because whatever we say, they don't understand exactly.
Myopes.
Yeah.
Thank you, my co-speakers, for accepting the talk and giving a good lecture. Thank you so much. Thank you for the attendance.